Good morning. Thank you for coming today. It is my pleasure to introduce Dr. Lucian Chirieac, who is an associate professor at Harvard Medical School and also at Brigham Women's Hospital. And to just say a few words about Dr. Chirieac and his illustrious career that he developed, once he graduated from residency. He finished his residency at the University of Rochester, and also he followed that with two fellowships. The first fellowship also at the University of Rochester, the second one at MD Anderson in Houston, Texas. After that, he became a member of several very important committees, those that are, for example, those related to National Comprehensive Cancer Center Network, where he actually co-authored most of the guidelines as related to lung cancer, as well as to therapy management of mesothelioma. His clinical and research interests are in lung cancer, in mesothelioma, and also in tumor proliferation. On a more personal note, I will never forget not only that he is such a wonderful friend and always very supportive, always there to help you, but also I will never forget, how a perfectionist he is. And that is actually a good thing in pathology. It is a virtue in pathology. He worked, for example, in the spring of 2015, when I was preparing to give a platform presentation in mesothelioma and our findings in terms of molecular alterations in Malignant Mesotheliomas, Pleomorphic. He worked with me for hours and hours just to make sure that everything will turn out the way we both wanted to turn out for those only 10 minutes of presentation. So yes, it needs a lot of hard work. So please welcome Dr. Chirieac.
Wow, and I thought you forgot about those times in 2015. Well, thank you so much for Emil for inviting me here, and thank you for being such a gracious host with me since I came in yesterday. And in the next hour, I was planning to present to you some of the projects we did, actually one of them with you, Emil, regarding some of the advances in malignant mesothelioma and some of the advances in peritoneal mesothelioma, and some of my research endeavors in this field. Actually, this is we were talking earlier, this is a picture of the Harvard Medical School. I don't know if you know, but it was purchased with marble at the heavily discounted price from Rockefeller. He wanted to use it in New York City and actually was defective. So the time, more than 100 years ago, Harvard Medical School purchased it at more than 30% discount. So what I'm going to talk today is, the talk is going to be structured in four major parts. The first one, I'm going to offer you an introduction about the malignant mesothelioma, the plural type, the major histological types and why they are important, and the significance of classifying malignant mesothelioma, some things about the immunophenotype of malignant mesothelioma. And the second and the third part are basically describing the clinical importance of two of the most common alterations in malignant mesothelioma, the role of BEP1 or BRCA1 associated protein in the diagnosis of malignant mesothelioma. Secondly, the other common alteration is the role of P16 deletions in the diagnosis of malignant mesothelioma, and I will present some of the areas of interest in this field. And lastly, it's one of my dearest projects that was recently published, and it's basically one of our discoveries in a cohort of patients with peritoneal mesothelioma, the identifying ALK abnormalities. So to start with the introductory notes, the Classification of malignant mesothelioma is based on histology, and it's the most important prognostic factor independent in these patients. Therefore, classifying mesothelioma is extremely important. It comes in three major flavors. 60 to 70% of the patients have epithelioid malignant mesothelioma. The second major pattern is the sarcomatoid or spindle cell pattern. It's in about 10% of the patients with malignant mesothelioma. And the rest, about the remainder of the patients, it's a mixture of both epithelioid and sarcomatoid mesothelioma, and it's called biphasic type. Some of the biphasic mesotheliomas have a more predominant epithelioid morphology. Some of them have a more predominant sarcomatoid morphology. And again, this is probably in 30% of mesotheliomas. As I mentioned earlier, the classification has a major prognostic importance, and usually the patients that, despite the fact that mesothelioma, it's a dreadful disease, is probably one of the most aggressive malignancies. The patients that would be diagnosed with epithelioid mesothelioma, usually they have a median overall survival time of about 16 to 18 months on average. In contrast, the patients with the sarcomatoid morphology, they have a much worse prognosis of median overall survival of about 6 to 8 months. This disease is so bad that basically an initial diagnosis of sarcomatoid mesothelioma would render the patients inoperable from the get-go. The grossly mesothelioma usually comes in two presentations. About 50% of patients, they present with multiple nodules that are involving diffusely the pleural surface, whereas the other half of these patients, they usually have a diffuse thickening of the pleura, and usually this is the majority of the patients that present with a diagnosis of sarcomatoid mesothelioma. In the pathology laboratory, we identify usually more or less 4 types of specimen. The pleural biopsies, in majority of them, are performed by video-assisted thoracoscopic surgery, or VATS. These are by sampling under direct visualization by the surgeon. Then the pleurectomy decortication usually are on the patients that basically are not easily operable. Pleurectomy meaning the removal of the parietal pleural surface, diaphragm, and pericardium, whereas the decortication means the resection of the involved visceral pleural surface with preservation of the lung parenchyma. And probably one of the most brutal surgical techniques, extrapleural pneumonectomy, which means removal of the parietal pleura, diaphragm, and pericardium, and also of the lung. So in a nutshell, this is a pneumonectomy, which is done in a very extensive resection. I'm coming from a place with a very high tradition and long tradition of this kind of surgeries. When Emil was there, actually, this was a very widespread type of technique for these patients. It was pioneered by one of the surgeons that I was working with, Dr. David Sugarbaker. Initially, like 20 years ago, when he started to do this type of surgery, the mortality was huge. It was 20 to 30% used to die in the next perioperative period. In time, he perfected the technique, and basically, at the present time, the mortality for this type of surgery is about 1 to 2%. And the main reason for that is basically a very strict selection of the patients. So the patients that are getting this type of surgery are extremely healthy patients that and very young that are able to undergo this type of surgery. What I have to tell you, though, is this was for many years was the considered the best surgical technique for these patients. There are multiple studies nowadays that basically are comparing between pleurectomy, decortication, and extrapleural pneumonectomy, saying that mostly, this technique is nowadays preferred to this one. And lastly, patients that have this extrapleural pneumonectomy surgical technique would have also heated chemotherapy, which is applied in the pleural cavity, and local radiation for microscopic disease control. So the next couple of slides I'm going to show in a nutshell what extrapleural pneumonectomy means, is starting with an incision in the intercostal space, and basically resection, if you want, of the diaphragm. This is parietal pleura by the surgeon, and then creating a pericardial window. Notice here, that's the reason it's called extrapleural. And basically the lung, which is underneath both the parietal and visceral pleura and the diaphragm. Actually, this is how the resection is done, and is done with a very blind dissection with the surgeon hand to be able to remove the entire specimen in only one step. And again, all these windows, they're patched with Gore-Tex, basically like a ski jackets, Gore-Tex material here and on the diaphragm, and this entire open cavity is going to be then applied with heated chemotherapy. So much for this type of surgery. We used to have maybe tens or if not hundreds of specimens like that. Nowadays, again, the number of in Brigham, but now this type of surgery is decreasing. A couple of words now about the introductory. How do we make the diagnosis in mesotheliomas? Obviously, we use at our. I'm not sure about the panel that is done here, but in our institution, we are using a panel of 3 immunostains which are specific in carcinomas, and to make the differential diagnosis between epithelioid mesothelioma, which is on the left-hand side of your screen, and adenocarcinomas on the right-hand side. We use 7 immunostains. The AE1, AE3 basically it's not able to make the distinctions, but it's a very nice stain to kind of emphasize the degree of invasion of the tumor into the fibrous tissue and adipose tissue. And we use 3 stains that we call them mesothelioma stains, that are extremely, they're supposed to be positive in epithelioid mesotheliomas. This chart shows that basically D240 and calretinin are extremely sensitive, so in other words, they stain all the mesotheliomas, but some calretinin could stain some of adenocarcinomas. The same is true for D240, but there are 2 very sensitive stains. In contrast, WT1, it's extremely specific, stains the majority of mesotheliomas, but does not stain any of the adenocarcinomas. In addition, we use the polyclonal CEA and Claudin-4. There are 2 very good stains that are positive in adenocarcinomas, and of course TTF1, just if the differential diagnosis includes a lung adenocarcinoma. And I'm going to show you next few examples of the patterns of staining. A1, A3 showing how the mesothelioma, the main, as you know, the main diagnostic criterion is invasion of the mesothelial cells. In this case here in the picture, you can see how the mesothelioma cells are invading into the adipose tissue. Calretinin, we love when calretinin is positive and has also not nuclear staining, but also the cytoplasmic staining. Extremely sensitive stain. And here WT1, very good and very important stain for extremely specific for, in this context, for epithelial mesothelioma of the pleura. Things change a little bit in peritoneum, especially in the differential diagnosis in women. But for pleura, this is a very good stain, which we're using it every day. WT1, some of the carcinomas have this very peculiar cytoplasmic staining. Because it's not nuclear, it's considered negative, but there are many cases that could stain in this fashion, and care should be applied to interpret this as a negative stain and not a positive nuclear staining. And D240, this characteristic, very nice membrane staining of D240 that it's usually extremely common in epithelioid mesotheliomas, less common in sarcomatoid mesotheliomas. Polyclonal CEA, we use it, and again, this is to in the differential diagnosis, and this is a case that was positive for polyclonal CEA, a case of carcinoma involving the pleura. And a TTF1 on the pleural surface showing a lung adenocarcinoma that was involving pleura. Moving forward, a couple of years back, some of my colleagues from different other centers, they were extremely focused on subclassifying mesotheliomas, not from the epithelioid and sarcomatoids. Thank you. And multiple papers have been published trying to show the importance of some of these architectural patterns similar to lung cancer. As we know, in contrast to lung cancer, where the classification is based on architecture, papillary, micropapillary, solid, and so on, the classification is in mesothelioma, it's very simple, or it's supposed to be very simple, and again, based only on the shape of the cell. So the cellular type, either if it's round, like in epithelioid, or if it's spindle, like in the sarcomatoid mesothelioma. However, many efforts and hours of research have been focused on trying to sort out this, this long laundry list of patterns in mesothelioma. What I can tell you at this present time, they basically don't make absolutely any prognostic significance. We don't put that in the pathology reports. The only one which is probably worth mentioning it, and it's a good one, it's pleomorphic, because as we know, the malignant mesothelioma is by definition a disease where the cell is extremely monomorphic. It's very homogeneous. The cells are round. They're exactly almost similar with benign mesothelial cells. Hopefully I'm not offending any cytopathologists in the room. But I'm going to talk about some of the newer diagnostic techniques in mesotheliomas. But just to mention that pleomorphic morphology became extremely important in this situation because it has been shown, and this is from two cases that I choose to present for you, that the pleomorphic morphology, basically it's a very unique morphology in the epithelioid field of malignant mesothelioma. Usually it's in about 10% epithelioid mesothelioma, and these patients that have pleomorphic morphology of their epithelioid mesothelioma, and here it's some other pleomorphic morphologies from one of the studies we've done some recently. This is the importance of it. So, basically it has been shown that the patients with pleomorphic morphology, they have a very bad prognosis. So their prognosis is so bad that it's almost similar with the sarcomatoid mesothelioma, and much worse, as you can see here. And we, that's the only type of morphology that I put in my report, and usually the surgeons would know that not to operate on these patients because the outcome is dreadful. Again, here median overall survival times are similar to the sarcomatoid morphology at 7 months versus 15 months in this type of patients. So I'm going to switch gears now from the part of the diagnosis, what we use in the immunohistochemistry, and basically to start presenting some of the the ways we got to the molecular biology and the diagnosis of malignant mesothelioma. For years, this was lagging behind, and one of the reasons for that is we didn't have enough tissue to perform the molecular studies. And understanding the molecular pathogenesis of genomic and epigenetic alteration for the development of mesothelioma, again, it lagged behind of other malignancies. Recently, developments of novel methods for genetic and epigenetic analysis revealed fundamental molecular abnormalities of malignant mesothelioma, and I would like to present some of the most recent developments in this field. And again, there are some reviews describing this comprehensive list of molecular alterations. And this is these are the findings from a project very dear to me and to Emil, which was performed by Emil when he was at the Brigham and Women's Hospital. He basically collected more than 50 patients and their molecular analysis done by a targeted hybrid captured next generation sequencing using this HiSeq platform, using entire exon sequences of 275 genes and selected intron coverage of 30 additional genes. Also, he used to determine the overall number and type of mutations, but not only mutations, but also copy number variation in all these plural mesotheliomas. And at that time, this was one of the most comprehensive molecular study of malignant mesothelioma, and this was done for two major reasons. On one hand, we had a lot of very large collection of tumor tissue at our institution. And secondly, this was done on a prospective basis for high generation sequencing, which was done in more and more tumors at that time. So Emil was at the right place, the right time to do these particular investigations. And these are basically what he found, that each one of these bullets represents a case. You can see here that these are all the cases that are used in his investigations, and you can see that at least in each one of the tumors he found at least one alterations, and basically showing that the median number of alterations are basically 3 mutations per cell. Obviously, some they have 1, but there are some other mesotheliomas they have between 6 and 9 mutations per tumor cell. So basically, this is a tumor that has multiple mutations in their genotype. And that basically, this is another showing that of the 53 tumors that are investigated in his project, basically, this showed the genomic events in malignant mesotheliomas, the most common one from the most common to the less common one. And this one basically showing that the copy number variation in the light color and the mutations are depicted in the darker color. You notice here the 3 most common alterations are alterations in the, as I mentioned before, BRCA1 associated protein 1 or BAP1. The second most common CDKN2A, and the third more common neurofibromatosis 2 gene that were depicted in this chart. So the most common ones, again, the homozygous 9p21 deletion center on the cyclin-dependent kinase inhibitor 2A gene, the more of the 72% of the tumors, neurofibromatosis NF2 loss through monosomy 22 or 22q deletions, and the most common one, the BAP1 mutations. And I just wanted to spend some time on this type of mutations because these are recently we finished reviewing like more than 700 mesotheliomas that were regarding the immunohistochemistry of BAP1, and basically the immunohistochemistry of BAP1 reflects genetic alterations in this particular gene. So next I'm going to talk about the role of BAP1 in the diagnosis of malignant mesothelioma. This is the structure of the protein, and it has this is a deubiquitination type enzyme, and the two most important segments for this protein to function is the active site, or the UCH, ubiquitin carboxyl hydrolase moiety, and the other one is the nuclear localization signal. And you can see here the majority of molecular alterations are either in this site, on the active site, or in the nuclear localization moiety or domain. What happens is that when we find mutations on this site, basically the protein it's completely non-expressed. In other words, immunohistochemistry for BEP1 is completely negative. If we find mutations in this domain, the protein is produced. However, it's, instead of being localized in the nucleus, is going to be localized in the cytoplasm. So a nuclear immunohistochemistry stain will reflect a non-mutated wild-type protein, whereas absence of the nuclear expression reflects a mutation in the active site, or alternatively, mutation in this domain would reflect a positive cytoplasmic expression. And BEP1 is a tumor suppressor gene. As I have shown you from Emil's study, BEP1 is mutated in malignant mesotheliomas, and usually these are somatic mutations. However, like about 7-8 years ago, there started to appear a lot of families. They have germline mutations, and soon after the first cases were described, a new syndrome which was identified or called BEP1 inactivation syndrome was described in some of the families that have this germline mutation. And the major characteristic of these families are that they develop multiple cancers in family members. And starting with the somatic mutations, so this BEP1 is not only common in the tumors in malignant mesotheliomas, but there are mutations in multiple other tumors, uveal melanomas, atypical spitzoid tumors, melanomas, and some of the renal cell carcinomas. All of these tumors could have BEP1 alterations in their genotypes. And this is basically from a study that we recently published, showing, for example, that BEP1 in this particular mesothelioma, BEP1, which is intact, so there is positive nuclear staining. In contrast, some of this here, this could be some control like lymphocytes that should be positive, but there's absence of nuclear and cytoplasmic staining in a majority of mesotheliomas. This feature actually has been recently described as one of the most important diagnostic tools that we have to separate benign mesothelial proliferations from malignant mesotheliomas. We use BEP1 daily, so basically I perform immunohistochemistry chemistry for BEP1 for all the mesotheliomas, or when there is a discussion between benign proliferations and malignant proliferations, because in the cases where there is for sure those cases are malignant. If the immunostain is negative, in other words, if there is nuclear expression, we don't know for sure if this is malignancy or not, but in cases where the BEP1 nuclear staining is absent, it's an extremely powerful tool to diagnose malignancy. And coming back to cytopathology, our colleagues, at least in my institution, use BEP1 on a daily basis to separate benign from malignant mesothelial proliferation. And I think that's one of the most recent powerful tools we have in distinguishing between these two entities. I've seen only a few cases that have germline mutations, and again, there are families that have increased susceptibility for the development of several tumors. Multiple patients have actually 2 or at least 3 tumors in the same time. The most common ones are uveal melanomas, ASTs or atypical Spitz tumors that basically they were baptized M-BAIT or melanocytic BEP1 mutated atypical intradermal tumors. Some of these patients developed these Spitz tumors in their 20s, and they, especially in the dermatopathology and dermatology areas, they became a very interesting field to study. And again, some of the patients developed cutaneous melanoma, and some of them malignant mesotheliomas. And I've seen one actually a case with multiple sisters that have malignant mesothelioma, and actually the case that I was consulted on had mesothelioma and renal cell carcinoma at the same time. And this shows that some of the reported families, of the time there are not many families that are reported. However, the number increases every year because we are becoming more and more aware of this type of entity. Again, malignant mesothelioma at the top of the list. Out of the 76 cases described, 22 had malignant mesotheliomas. And again, the most common tumors, uveal melanomas and cutaneous melanomas, in the same, as more common tumors. And again, patients, as I said before, with 2 or more malignancies, 13 out of 76 described had at least 2 cancers in the same time. And some of the, again, the Spitz tumors or M-BAITs that are in some of these patients. And this is an example of clinical presentation of this patients with these atypical Spitz tumors that from macules and papules, and this is basically they're not very large, but this represents some sort of initial presentation in these patients. And if you do perform a biopsy basically of this nevi, this actually at higher power magnification reflects cytoplasmic staining and not nuclear staining. In other words, there is absence of nuclear expression, and this patient actually have mutations into the nuclear localization domains. Some words about the, in the third part of this presentation, of basically what is the role of p16 deletions in the diagnosis of mesothelioma. This type of abnormality, however, requires the utilization of FISH, fluorescent in situ hybridization. We do not perform this commonly. Probably very few times I've seen this happening in our laboratory. However, I know there are institutions that are heavily focused on using p16 deletions in the diagnosis of malignant mesotheliomas, especially in the sarcomatoid mesothelioma. It's where you know that basically there is a the differential diagnosis between sarcomatoid malignant mesothelioma and the reactive sarcomatoid or spindle cell proliferations of the pleura. It's extremely, or could be extremely difficult. And this is one area where p16 deletions could help us in making this diagnosis. This is a marker for, again, separating benign from malignant mesothelial proliferations. p16 INK4A is a cyclin-dependent kinase inhibitor and a member of the INK4 family of cell cycle regulatory proteins that bind and generally inhibit D-type cyclin-dependent kinases. There are some, this abnormality is not specific to mesothelioma, and there are some homozygous deletions of the p16 gene locus. Some of the tumors, including carcinomas of the bladder, breast, and prostate. And as I mentioned before, a proportion of mesotheliomas have homozygous deletions of p16 when assayed by fluorescent in situ hybridization. We looked with some colleagues from a different institution, and we found that basically there are deletions in up to 80% of primary pleural mesotheliomas, depending on the histologic type. We described that basically almost all the sarcomatoid mesothelioma have this abnormality. And some of the epithelioid and mixed subtypes have 70% P16 deletions. In contrast, in approximately 25% of peritoneal mesothelioma, this is encountered so much less proportion that the pleural mesothelioma. Therefore, as I mentioned before, the detection of deletion can be a useful approach for distinguishing benign from malignant mesothelial proliferations. This is an example of a case that was not deleted. You notice both the green and red signal, and here in a case where it's deleted, the complete absence of the red signal in the tumor cells. And this is showing that basically in sarcomatoid tumors of the lung and pleura, again in sarcomatoid mesotheliomas, we're dealing with a homozygous deletion. In contrast, some of the sarcomatoid carcinomas, they have hemizygous deletions, and some of these recurrent solitary fibrous tumors showing a combined homozygous and hemizygous deletions. So, starting from that observation, some of my colleagues, and Andrew Chirieac actually is going to published already one of the projects that I'm going to present further, showing that in this molecular abnormality could be extremely useful in cases where we are dealing with the surface proliferations, and we don't know because of the histology if that surface proliferation is part of a malignant tumor that kind of spread along the surface, or is basically just a benign reactive proliferation. And this is where to say that mesothelial proliferations confined to the pleura, to the surface, are a diagnostic problem since they lack invasion. We'd like to see invasion as the major diagnostic criterion in all the mesotheliomas. However, sometimes we don't have this luxury. Sometimes the biopsies are not deep enough to show us the invasive pattern of these proliferations. Some of these proliferations are malignant, either because they represent mesothelioma in situ, from which an invasive tumor has developed, or because they represent surface growth of an underlying invasive tumor. There are no criteria that on H&E staining predict which lesions are malignant and which are benign. And as is the case for the BAP1 immunohistochemistry, we can use here FISH for P16 deletions for the surface proliferation. And if we are lucky enough to find a deletion, that means that proliferation is malignant. In contrast, the absence of deletions were not going to help us in any way. And it's basically the same here, showing the case of a P16 deletion in both malignant mesothelioma and the surface mesothelial proliferation. And the project, which was published by the group led by Andrew Chirieac, showing the same tumor here on the surface and on the deep invasion, both in the the deletion in both. And here basically showing a P16 intact signal in both malignant mesothelioma on the surface, and here invading into the neighboring adipose tissue. So, in conclusion, we identified this BRCA1, and it's a beautiful antibody. It's commercially available. We use it. It's been very helpful. Right now, what I have to say in this BAP1 interpretation immunohistochemistry story, that we like to be straightforward and to say, well, it's nuclear staining, it's cytoplasmic staining, or it's absence of staining. In reality, probably 80% are clear-cut cases. However, we identified, and this is a work in progress, about 20% of mesotheliomas, or we see some sort of a clonal selection and heterogeneity. I've seen tumors that are becoming kind of crazy to interpret with positive nuclear staining. Some they have absence in the same tumor. So there are some tumors that the signal is not clear cut that we like to be. P16 very important. We don't use it for fish, but I know there's some other academic centers that use this. It takes a long time for turnaround. At least in our center, if you say you're not sure about the diagnosis, probably the next day the surgeon is going to go in and do a second biopsy just to make things more clear for everybody. So lastly, I'm going to talk about a very recent observation we made, and we recently published in JAMA Oncology, identifying in a subset of patients ALK-rearrangements in malignant peritoneal mesothelioma. As you know, ALK was more than 20 years ago identified in a subset of lymphomas. It became a very hot topic where the rearrangements were identified in lung cancer. About 5% to 10% of patients with lung cancers usually have ALK rearrangements. There are at least 2 targeting drugs that have been approved for targeting lung cancer with ALK rearrangements. One was FDA approved in 2011, crizotinib. There are more and more cancers now that, in addition to lung cancer, that have been identified with ALK rearrangements. We looked in basically this was basically some sort of accidental observation. We had a patient with very young patients with a very peculiar peritoneal morphology. We started to work it up, and basically we identified that that particular patient had what's called ALK immunohistochemistry, and then we went back and we looked at all the peritoneal patients with peritoneal mesotheliomas. These are extremely uncommon cases. I mean, I'm talking peritoneal mesotheliomas. If you imagine that in United States of America, around 3,000 new cases of peritoneal mesotheliomas are diagnosed, the number of peritoneal mesotheliomas are 300, so 10 times less. So 300 patients, new patients per year, it's a very limited number. It's an extremely uncommon disease, and most commonly identified or diagnosed in women. When we looked at all the backwards to all the patients with peritoneal mesothelioma, we identified a very limited cluster, like about 3% of cases that present in young women. We did the asbestos investigations, and actually all these cases, they lack asbestos fibers. They lack a history of therapeutic radiation. This is another major cause of inducing mesothelioma, pleural or peritoneal. And what was more interesting, they lack the typical cytogenetic and molecular abnormalities usually present in peritoneal mesotheliomas. And actually, patients with peritoneal mesos, they have similar abnormalities with the ones that were identified by Emil in the previous study I have shown you about. And this, what we found when we stained all the cases for ALK, 3%, they have a beautiful staining for the immunohistochemistry. The majority was ALK was completely absent, but also we identified in 8% of the patients this very weak diffuse pattern of staining, and here by fluorescent in situ hybridization, you notice basically the rearrangement with this, which was diagnosed with this broke apart probe. So in normal cases, these two probes overlap, so they give a yellow signal. However, in this ALK-rearranged cases with a break apart probe, you can see both probes breaking apart. And in the middle, we see these cases with weak staining, basically the polysomy that was pretty non-specific, but it's still there in about 8% of the patients. And these are like basically the patients that were identified. Some of them, they have this papillary architecture, some more like diffuse invading patterns, and here more of a classical pattern, epithelioid pattern, with this very round homogeneous cells that are invading into the neighboring stroma. And from our study, we have shown that when we plotted this on this heat map, we have noticed that all these patients with ALK-rearrangements, basically they do not have any of the most common molecular abnormalities that are identified in the mesothelioma, the molecular alterations in BEP1, SETD2, and neurofibromatosis 2 gene. And these are the amino acid sequences of the patient that we have seen. On the right-hand side is from the ALK and rearrangements with this STRN, ATG16L1, and TPM1 tropomyosin in the partners for the rearrangements in these patients. So to summarize for today's talk is basically some of the most important take-home messages that the epithelioid mesotheliomas with pleomorphic morphology has a poor prognosis similar to sarcomatoid mesothelioma. This is important to tell our surgeons about our patients. Sustained efforts in modern high-throughput technologies have allowed to uncover novel genomic and epigenetic abnormalities in mesotheliomas. BEP1 mutations in mesothelioma could have major implications in the workup of patients with mesothelioma, and this is probably one of the most helpful, I see, areas of development in this field. P16 deletions, probably less common in the pathology laboratory, in helping distinguishing between benign and malignant mesothelial proliferation. And lastly, we described clinically actionable ALK-rearrangements that are novel and represent a novel mechanism in a subset of peritoneal mesotheliomas. And this, we're looking for patients now to see if this could have promise for targeted therapy in the near future. So with that, I'd like to thank you, and I'll be happy to take any questions.
So for ALK-mutated in peritoneal and malignant mesothelioma, we have a couple cases of younger women. Do you see that more coming in the younger patients? What's the percentage of that rearrangement?
We saw it in women only. We also went back actually and investigated more than 200 patients with pleural mesothelioma, and we couldn't find any ALK abnormalities. But having said that, last week I saw the fourth patient that was a man with a peritoneal mesothelioma. So I think the more we are aware, and that's probably my duty to make people aware of that, and because ALK immunohistochemistry, it's a pretty common immunohistochemistry, it's a common immunohistochemical stain, and this could be easily identified and could be easily performed in every pathology laboratory. So yeah, I think the sooner we identify this, and also with this publication, we got a lot of patients that probably they're reading the literature, they want this performed to see if indeed it's they're right. And
what's the percentage?
3% we found. We looked back then, and some of I also asked some of my colleagues if they have cases, and they identify some. We talked this morning. Maybe we can extend our collaboration here too. If I don't know the prevalence in each academic institution, but I think the more we're going to get, in Europe actually, some of the colleagues we worked with, Dr. Françoise Galatos-Alessi identified another patient. I'm not sure. I don't think there are many, but I think it would be useful for the patients that indeed have this abnormality to have at least tried therapeutic targeted therapy.
Yes, please, John.
What's the mechanism of asbestosis in inducing, or asbestos in inducing some of the genetic abnormalities that you talked about?
So the question, what is the molecular mechanism of inducing cancer in patients exposed to asbestos?
Right.
The mechanism is not entirely known. There have been a lot of hypotheses for that, including oxidative stress, and some of them talking about the mechanical approach of the asbestos fiber when it's inhaled into the lung, basically getting to the parietal pleura, visceral pleura, parietal pleura, and then basically some mechanical lesion of the chromosomes. There are many hypotheses, but I'm not sure if there is a very well-known mechanism that is completely separate from some other mechanism, for example, from the radiation-induced mesotheliomas. What I think it happens is probably, we have a project, and Emil's project, showing that multiple alterations are in this, they are found in this cancer cells. So I'm not sure it's very well known. To answer shortly on your question, there's many mysteries left behind. There, for example, one of them is that actually mesothelioma starts in the parietal part of the pleura and then goes to the visceral pleura. There have been some patients that had only the parietal mesothelioma described, and this is pretty kind of unexpected, and it's counterintuitive for us. And I think more is to learn from that. We don't know the mesothelioma in situ kind of component, if it still exists, or when are the earliest type of events in the oncogenesis of mesothelioma.
Yes, sir.
So might actually have two questions, but I'll start with the first one, which is actually in the P16 story. So in the benign surface proliferations, one might hypothesize that there's RB alterations, other cell cycle alterations that could actually lead to increased basal P16 expression. Have you actually looked, rather than at the fish, looking for CDKN2A genomic deletions? Is there any room for P16 immunohistochemistry in there, or is it just too low?
P16 immunohistochemistry, we did look. Actually, I had to collaborate with someone, with Dr. Dasik from Pennsylvania in this, and apparently there's no correlation between P16 immunohistochemistry and the deletions. So, because a lot of
most of them are probably negative anyways. I was just wondering if perhaps there's enough RB alterations in the benign that were consistent.
People could not find any significant or clinically important correlations to kind of overcome the fish.
Yeah, sure. And then the second question I've had was with the BAP1 altered mesotheliomas, is there enough that's been done on a basic science standpoint from those to understand if they truly have a double-strand break deficiency? And within the BAP1 germline cases, is it well known that it's actually the same BRCA1 homologous recombination DNA repair pathway that's altered?
Maybe. I don't know how to answer this. I'm not familiar with the
we're going to meet later, so we can talk about that. But that would be one potential therapeutic intervention, because A, those patients could be candidates for PARP inhibitors, and then B, again, whether or not some type of a platinum-based regimen might actually be better for those patients would be an interesting hypothesis.
What's been, and I think the field is not pushed by the mesothelioma folks, but are mostly pushed by the dermatopathologists and usually dermatologists, because they believe that all this like small maculopapular lesions could be if they are identified in young patients, these patients could be followed more closely and more carefully for some more dreadful malignancies like the mesotheliomas or renal cell cancers or lung cancer that are developed very early in their lifetime, in the 40s. So 30s and 40s, people develop these cancers.
Lucian, I have a question myself. Sorry, Maggie. So please go ahead.
I was just wondering, in relation to the subset of cases that have the BAP1 mutation, if it was more common in epithelioid versus sarcomatoid, and then also if you knew that same exact question, the answers for it in uveal melanoma, because it tends to be opposite, where the epithelioid is associated with a poor prognosis. And just if you found anything that correlates with that being a prognostic marker.
In mesotheliomas, it's more common in the epithelioid side. It's less common in the sarcomatoid side. Histology. I don't know the story about the melanomas. Some investigators looked into the possibility of diagnosing biphasic mesothelioma, because the assumption was that if it's a biphasic histology, cases with lack of BEP1 expression would have mutations in both epithelioid and sarcomatoid histology, and there are some papers out there. However, I have to tell you that I've seen at least 3 cases that are very clear-cut biphasic histology with both epithelioid and very sarcomatoid obvious histology, but they have absence of BEP1 in the epithelioid and they have intact expression in the sarcomatoid. So I think it's more to be done and more work to be done in this field. I don't see the explanation on this. Is probably there's some sort of a clonal variation between the two histologies, and but those are cases that are worth mentioning it, because as you know, sometimes it's extremely difficult to make a diagnosis between a biphasic mesothelioma with a very clear sarcomatoid histology and an epithelioid mesothelioma with a desmoplastic, very wild desmoplastic reaction. And this is where we are right now. And it appears to make a very important, be important in the therapy and the classification and so on.
So I have a final question. Please.
Is the benign mesothelioma also epithelioid in nature?
Benign mesothelioma, we rarely use that term anymore in the benign mesothelioma right now, but basically all the benign proliferations do not have any molecular alterations whatsoever. So again, this is one of the clinical scenarios where we'd like to use this tools to make the distinction between benign proliferations and malignant ones.
So I have a final question. So about 25 years ago, when we started to see actually a decline in cases in the incidence of malignant mesothelioma, we all got very excited that we are finally getting rid of this dreadful malignancy. But would you please expand a little bit about the tendencies, because it doesn't actually appear that will be the trend as we move forward.
We see that the trend is coming down in America, especially in men. But I think what we're left in more in the years to come, a lot of this asbestos-induced mesotheliomas will kind of go down because the exposure it's declining. So people are not exposed to this, occupational or bad occupations where people were sniffing asbestos fibers daily. But I think this is going to be like one of those common diseases that are in the future are going to have the same incidence in men and women, like the peritoneal ones, which are known to be less linked with asbestos exposure, and probably that's going to be true for pleural mesotheliomas. We're going to see more and more of this. I think this story is paralleling a little bit the story of lung cancer, where you see more and more of uncovering this, HER2 positive lung cancer, ALK-rearranged lung cancer, ROS1, and so on. So we're going to have all these little slices of the pie of this unknown pathogenesis of lung cancer. I think that's what's going to happen now in the field of mesotheliomas. And I know there's another group that published some specific alterations in pleural mesothelioma, just a subset, but this is where I think it's going to happen in the next years, and we will be able to uncover more and more of these molecular alterations.
Thank you very much.